and the most common site was mid-esophagus. So as you know, esophageal is the most, the major public health problem globally, but it's most common. The impact is most common in low and middle income countries. So according to the Globocan 2020 report, it is the seventh most common cancer, and it is the sixth leading common cause of cancer deaths globally. And more than 50% of the patients, they will present as inoperable disease stage, either locally advanced or metastatic disease. So as the disease increases, the dysphagia, the presentation with dysphagia increases, and this will lead to pain, poor nutrition, reduced performance status, and decreased quality of life. So the selection of the palliative treatment or palliative modality, it depends on the major different factors, especially like the patient characteristics, the presence or absence of comorbidities, performance status, severity of the dysphagia, the tumor burden, and the location also are very important to select which modality is important. And the expected survival should also be considered. And the previous treatment that the patient took should also be considered when we consider treatment, the palliative treatment for dysphagia. So there are different options, as I told you, like endoscopic procedures, the body dilation, the chemical, thermal, self-expanding metal stents, the surgical options. But I'm not going into detail about the other options because I'm going to focus only on the oncologic treatment with radiotherapy, chemotherapy, and concurrent chemoradiotherapy, which is a combination of chemotherapy and radiotherapy. So our discussion is in focus of this oncologic management of dysphagia. So the first option of treatment is radiotherapy. So radiotherapy can be used alone or in combination with other modalities of treatment. So when we use radiotherapy, the patient should have a good performance status, and the tumor is when the tumor is not suitable for more radical treatment, like because of the length of the location of the tumor, and when there is regional or distant metastasis, usually radiotherapy is a preferred mode of therapy in such kind of cases. But as you can see from the screen, the most common limitation of using the radiotherapy is it is lag time of the symptom relief. Usually it needs around 6 weeks of after treatment to get the relief after the treatment. That is because of the different modalities of action because of the radiotherapy. So there are two types of delivering radiotherapy, external beam radiotherapy and brachytherapy. So the first one is a brachytherapy, or we can call it intraluminal brachytherapy. So in this case, what we do is you insert the radiotherapy source guided by endoscopy into the lumen of the esophagus. So usually we use iridium-192 as a radiotherapy source. So the advantage of this modality of radiotherapy is it can deliver high doses as high as like 28 grays in different fractions over a short period of time, and it is usually suitable for elderly patients that are frail to accept any other management, and it's cost effective as compared to the other modality of treatment. And for better quality of life, we can use brachytherapy. But the dose homogeneity is a bigger problem when using brachytherapy, and it is less effective as compared to external beam radiotherapy. And as I can see from the poll test initially before the presentation, it is used in limited centers because it requires, expertise that can work together from the upper, that can work together from the endoscopic side and from the oncology side. So expertise are needed to insert the brachytherapy treatment. That's why it's not using in most of the centers in Sub-Saharan Africa. So the dose and the schedule is variable. So as you can see from the slide on the right side of the slide, So when you insert the radiotherapy source like radium-192, so you'll create, you are giving radiotherapy in a very specific site of the esophagus or around the tumor. So the red things, the red areas that you have seen, that you are seeing on the slide, are those areas that are getting a larger dose of radiotherapy. So the bigger advantage of using brachytherapy is that it will spare other organs, vital organs around the esophagus, like the heart, the lung are spared, because as you can go on peripherally from the esophagus, as you can see from the slide, these the blue lines, the green lines, they are getting a very small amount of radiotherapy. The only concentrated site of radiotherapy is the central line. But as you can see, the dose is very inhomogeneous and it needs a big experience to administer this radiotherapy. So this is what we have in brachytherapy. The other mode of administering radiotherapy is external beam radiotherapy, or we call it in other name like teletherapy, because you deliver the radiotherapy from a given distance. Usually it is like 1 meter or so. Particularly, it is useful in bulky tumors. In brachytherapy, when the tumor size or the location of the size of the tumor is more than 10 centimeters, you can't use brachytherapy. And if even the circumference of the esophagus is completely destroyed by the tumor, you can't use brachytherapy. So instead, in these cases, you have a choice of delivering the radiotherapy using external beam radiotherapy. So there are different modes of delivering external beam radiotherapy, like 3D conformal radiotherapy, intensely IMRT and VMAT. So these are the newer versions of delivering radiotherapy. So in these modes, what we are trying to do is to deliver the radiotherapy using the in the volumetric and the intensely modulated types of radiotherapy. So you can modulate the intensity of the radiotherapy and according to the volume and according to the intensity to each specific organ. So you can give like 20 gray, and the problem with this external beam radiotherapy is the same because of the delay effect. So as you can see on the right side of the slide, while using external beam radiotherapy, you just give radiotherapy from two sides. The beams are from the in front and the back side, and sometimes we use also a four beam schedule. So as you can see from the slide, it doesn't spare other vital organs like the heart, the lungs, the spinal cord are also included in the radiotherapy, even though the amount of the radiation that they are getting is different among the different organs. So as you can see, the esophagus is getting the largest amount of radiotherapy, that is in yellow, and that is the next organ that is getting radiotherapy in large. That's the organs that are surrounding the esophagus. So as compared to the brachytherapy, it is effective, but it has a disadvantage of delivering radiotherapy to other organs as well. In some patients, dysphagia during administration of this external beam radiotherapy, because of radiation-induced esophagitis, patients may present with transient odynophagia or painful dysphagia, painful degradation. So in such kind of patients, we may need alternative route of feeding and hydration during the administration of radiotherapy. So such kind of consideration should be considered. The other option of treating patients with dysphagia is combining chemotherapy with radiotherapy, which we call it concurrent chemoradiotherapy. Usually, right now, it is considered as an aggressive treatment for palliation because unless and otherwise you have a low, you have the intention of curing the patient in metastatic and locally advanced patients for palliation purpose, it's not recommended usually to use concurrent chemoradiotherapy. because it has a lot of side effects like esophagitis, nausea, esophageal perforation in around 5% of the cases, hematologic complications like anemia, neutropenia, and also these patients at this stage, this metastatic stage and the locally advanced stage, they have a poor overall prognosis, and at the same time, we have other options, other effective options like expanding metallic stent, chemotherapy, radiotherapy alone, and so on. So in the presence of these options, it is hard to use concurrent chemotherapy for the mere presence of palliation. So currently, it's not recommended to use concurrent chemoradiotherapy for palliation. The other option of oncologic management for palliation of dysphagia in esophageal patients is chemotherapy. Usually, it is used in patients with metastatic or systemic disease, and those patients who have good performance status. So, studies they have shown that as compared to self-expanding metallic stent or other modalities of treatment, it might not be as effective as them, but it can be used as the first line treatment or as the first option of treatment because of the following reasons. One, it lacks the local toxicity like that of radiotherapy. As I said earlier, radiotherapy, whether it is brachytherapy or external beam radiotherapy, they can cause fistula, esophagitis, and so on. But when you use chemotherapy, there is no such kind of local toxicity. And the other importance of using chemotherapy is relatively, they have a rapid onset of action, and the effect is long lasting. And so this is also another advantage of using chemotherapy. And the other advantage is they are available in most of the setups, and I can see from the pool that most of the Sub-Saharan African countries are using chemotherapy as well. And the other factor that forces us to use chemotherapy is if you don't treat a patient while waiting for the radiotherapy, the metastatic disease will exacerbate, or it will increase. The disease will increase involving more sites. So the patient's performance status and the general condition of the overall survival of the patient will decrease. So when you give chemotherapy as early as possible, it will avoid delays in treating the metastatic disease. So these are the important advantages of using chemotherapy as early as possible, especially in setups where we don't have radiotherapy to offer as early as possible. So there was one study, a retrospective study done, comparing chemotherapy in patients and self-expanding metallic stent. So as you can see, after 8 months, dysphagia score was improved, even though it is not as such that of stents. There was a significant improvement in patients receiving chemotherapy. So as I said, they are not as effective as stents or other external beam radiotherapy, but they are a good option that can be adopted and that can be used in setups like ours because of the limitation of the radiotherapy. So in our country, for example, we have only one radiotherapy center right now, Black Lion Hospital, and the waiting time for radiotherapy is, especially for palliation, is more than 6 months. For curable treatment, you may have to wait more than a year. So you can't afford the patient waiting like more than 6 months or so while giving no treatment. So this is a good option for setup like us to offer for the patient. So as you can see from the slide, this is the NCCN harmonized guideline. This is the second version, which was published last year. So as you remember, NCCN guidelines, they offered for the Sub-Saharan African countries. So this is a good guideline, especially because as you can see, those options in beige are not available in Sub-Saharan African countries, either because of the cost or because they don't because of the cost, or they are not available in this country. So they are not recommending to use such kind of treatments. Rather, those options that are in black, they are recommended as a category on the recommendation. So as a first line treatment in chemotherapy option, as you can see, fluoropyridine preparations either for 5-FU or capecitabine in combination with oxaliplatin or cisplatin can be used. But other options like 5-FU with irinotecan or Taxol with cisplatin or docetaxel can be used. And I saw that a lot of centers in Sub-Saharan African countries, they are using either of these chemotherapy. So as I said, chemotherapy are a good options, at least for the initial palliation of patients presenting with severe dysphagia because of the esophageal cancer. So as a summary, the advantages and disadvantages of different modalities of treatment, I'll focus only on the oncologic aspect. So we said that brachytherapy is a single treatment. The successful with short tumors, especially less than 10 centimeters. Otherwise, if the tumor length is more than 10 centimeters, they are contraindicated. But as a disadvantage, they may cause perforation, esophagitis, ulceration, strictures, fistula, and there is no use in long tumors if the tumor length is more than 10 centimeters. And if the tumor patency, if the esophageal patency is obliterated completely, there is no use of brachytherapy, and very time lag as that of external beam radiotherapy. And in some people as well, even this time lag may reach up to 12 weeks. So it is a very long time. And there are some papers that show that you can combine either stent with external beam radiotherapy, so that the stent will give you the early alleviation of the symptoms, and the radiotherapy will give you the late relief from the symptoms. The other option of oncologic management is chemotherapy. That is effective with systemic disease and in patients with good performance status. So the disadvantage of chemotherapy is gastrointestinal and other toxicity related to chemotherapy. So in summary, as you can see, esophageal with metastasis, locally unresectable, local recurrence, and comorbidities with poor prognosis. The factors that we have to consider is the performance status of the patient, the estimated survival of the patient should be considered. So if the patient has a good performance status, we have all these options: stent, radiotherapy, chemotherapy, and concurrent chemoradiotherapy in very selected patients. And the other consideration is the survival. If the patient's survival is less than 3 months, there is no need to administer chemotherapy or radiotherapy because their effect is very delayed, especially for that of radiotherapy. So for such kind of cases, stent is a preferred one. But for those patients having survival expected more than 3 months, stents are followed by brachytherapy can be done, or brachytherapy can be the first option. And if it fails because of so many reasons, stents can be done. So this is NCCN guideline to the last version. So they recommend in patient with unresected locally advanced, recurrent or metastatic esophageal C, and the performance is good, less than 2. We have chemotherapy, palliative care, and base supportive care as an option. But if the performance of the patient is very poor, like 3 and above, only we can provide palliative care, like supportive care and pain management. So that's what we can do. And we have to avoid the use of concurrent chemoradiotherapy for palliation for the reasons that I discussed earlier. And we have to avoid double palliation. Like we have to avoid the stent and external radiotherapy or brachytherapy, even though this issue is controversial, as I said earlier, because there are some papers saying that this is a very effective way of treating patients because of the delayed effect of radiotherapy. Early we can treat patients with stent, and then lately the radiotherapy will take over. But at the same time, the side effect profile from the radiotherapy or the combined use of stent and radiotherapy might be higher. That's why most of the guidelines, they don't recommend to use double palliation. Especially there was one study done in Netherlands, and they recommend against the use of stent and external radiotherapy because of high toxicity in the use of these modalities. So this is what I have for today. And if you have a question, we can discuss further during the session. Thank you very much.
Thank you so much, Dr. Abdu. And if you have questions, you can put them on the drop box. There are some questions sent from AQI. So 50% of patients presenting with metastatic disease seems high. And what are some of the reasons for this late presentation? This is one of the questions. And the other question is it the esophageal squamous cell carcinoma most prevalent in Ethiopia as well? And how easily available is self-expandable metal stent? Is this fluoro-guided or not? And the other question, are these treatment options for both esophageal squamous cell carcinoma and EA? So, yeah, so you can start with some of the questions. For the stents, we can respond.
Yeah. Okay. So the reasons for the late presentation, as you said, more than 50% of the cases, they present either with locally advanced or metastatic disease. In our country, the delay is explained at many steps. Like there is a delay. There is a delay in the patient. Initially, they don't recognize their symptoms, and they don't go to the health professional or to the health facility as early as possible. And after getting into the health facility as well, because of the oncologic services are not, available in most of the health facilities in our country. For example, if you see the professionals, the oncologists is totally in the whole country for a population of 110 million people. There are only like less than 30 oncologists around. So oncology service is very limited in tertiary hospitals. And so there is a delay, secondary delay in the hospitals or in the health professionals. So if you ask patients, usually they will tell you, they complain about dysphagia, dyspeptic symptoms, and so on. And so they have been treated for simple dyspepsia, PUD, and so on and so on. So there is a delay in the cognition of the people from the patient side as well as from the professional side. And after even being diagnosed with esophageal cancer, they will reach the tertiary hospital after a long period of time because of so many logistic problems. One, these tertiary hospitals, they are available mainly, they are concentrated in their country, in the capital of the country. So to reach the city, Addis Ababa city, they have to travel, so many kilometers, so many thousands of kilometers, and most of them, they prefer not to come. And even after being told they have a cancer, they wait a lot of time because most of our people, they are poor, so they can't afford, and they want to come after, facilitating the financial reasons. And so all these reasons, they contribute for the delay in the diagnosis. So as I showed you, our data, out of the 7 patients, 4 of them, they have metastatic disease at present. And the rest 3, they have locally advanced disease, almost incurable, all of them are incurable. So I hope we need to study at which stage is the main delay, But these are the main issues, the main areas where the delays are happening. The other issue that is that was raised was squamous cell carcinoma was why it is common in your country. I don't know exactly the reason because, as you know, there is a so-called adenocarcinoma. Adenocarcinoma is nowadays becoming the predominant histologic type, but in our country, unlike the other countries, unlike the West, squamous cell carcinoma is becoming the most common type of histology. Maybe it is associated with the epidemiology of the thing is that the people, most of our people they are using. There are some studies that are done or published in Black Lion Hospital, and the most common etiology that was found was most of the patients, esophageal cancer patients, the reason was they are using hot meal or their staple diet was hot. So this must lead to metaplasia of the esophageal endothelium that can be transformed into squamous cell carcinoma. So it must be just my explanation. Otherwise, the main reason should be studied to answer your question properly. And the treatment, there is no difference whether it is adenocarcinoma or squamous cell carcinoma. The difference is when you come down, when it is esophageal, gastric, and the junction tumor, and when you have adenocarcinoma, rather than chemotherapy alone, you might add in such kind of patients, especially having locally advanced and metastatic disease patients, and when the histology is adenocarcinoma, you have to do HER2 immunohistochemistry test, and in those patients having HER2 positive, you have to add Herceptin or transformer targeted therapy. So that is the only difference. Otherwise, for esophageal treatment, for esophageal cancer treatment, whether it is proximal, mid, or distal, irrespective of the histology, the treatment is the same. But the treatment is different when you come to the esophageal gastric junction tumor and gastric adenocarcinoma. And I think the other issue raised was the self-expanding metallic stent. I think it's better explained by Dr. Alim.
Yeah, and Professor Mark has also experience in our setup, and he will tell us what he has seen.
We had a lecture completely about these stents from Dr. Machiro several months ago. So we won't try and repeat all that information today, but the organization African Esophageal Cancer Consortium has made it possible to get esophageal self-expanding stents at low costs in African countries. And so if you want to know more about that, you should email me or Dr. Machiro, who was on the conference earlier.
Yeah, Machiro was also.
We'd be happy to share information about how you can bring that program to your locality. I have a question for you, Abdu. Thank you for your excellent presentation. I think it's quite remarkable that you are palliating dysphagia with chemotherapy alone. And I think this is a big accomplishment for our patients. And I wanted to highlight it here at our conference, especially because now we are not the only ones who see a long delay waiting for radiotherapy. I think we've seen this from the poll questions at the beginning. So tell us, when you talk to a patient about palliating their dysphagia with chemotherapy, what commitment must they make? How many cycles? What kind of toxicity do you tell them to expect? And what percentage of the patients do you find really go for this treatment?
Okay. As I said earlier, the radiotherapy option almost it is unavailable for the population. Waiting for more than 6 months is unacceptable. So what we are offering is chemotherapy, palliative chemotherapy, and the most common options that we have is the 5-FU with cisplatin, 5-FU with oxaliplatin, the paclitaxel combination with cisplatin or carboplatin, or single agent chemotherapy with Taxol or docetaxel. So the usual cycle that we are giving for this patient is, since our aim of treatment is palliation, we are giving around 6 cycles, and we evaluate patients at the mid-cycle with symptomatically and using imaging, so that we decide whether to continue after the mid-cycle up to the 6th cycle, or we have to change the chemotherapy to other potent chemotherapy. So the initial plan is usually planned for 6 cycles of chemotherapy, and we evaluate at the mid-cycle, and we decide whether to continue or discontinue or to change the chemotherapy. And a full discussion with the patients about their disease, about what their expectation and our expectation is done. In average, for example, we spend around 30 minutes per each patient before giving them the chemotherapy, explaining them what is chemotherapy, why we administer chemotherapy, what chemotherapy adverse effects that we are expecting, and what to do for these adverse effects, and the outcome as well. So we all discuss all these things with the patients before administering the chemotherapy, and most of the patients, they agree to take the chemotherapy, and it is after the consent, after we get the consent to take the chemotherapy, that we are giving them the chemotherapy. And the problems that we are facing right now and since a long ago is the inavailability of the chemotherapy drugs. So there is a lot of, there is frequent disruption of availability of the chemotherapy. So patients, unless the chemotherapies are available, as you know, most of our patients, like 70% of our patients, are poor and they are being treated for free. When the chemotherapies are not available in a hospital, they have to buy in black market with a lot of money. So for that, they want, rather than buying the chemotherapy, they prefer not to buy the chemotherapy and discontinue the treatment. And during that time, the disease progress, and this has been a very challenging issue in our hospital. Otherwise, we have seen a lot of patients, we involved with chemotherapy, and in some patients who present with severe dysphagia, almost complete dysphagia, rather than giving the chemotherapy first, we insert feeding gastric feeding tube. Then we give them chemotherapy, palliative chemotherapy, and we assess if they can feed by themselves, and if we can remove the feeding tube after the dysphagia is removed. But this is possible only if we are assessing the patient from the outset. So we are doing it in such a way, and as you can see, we have seen a pretty, I think, a pretty good amount of patients in our center.
Thank you. I think for some patients, like patients with very proximal cancer, like the one you presented, stent has problems. So even when stents are available, plus chemotherapy is actually treating the cancer, not just treating the obstruction. So I think it's a fantastic option to have to offer to patients.
Yeah, from the oncology point of view as well, for proximal, local regional, proximal esophageal cancer, which is locally advanced. If you rule out the distant metastasis, the recommended treatment is to give them concurrent chemoradiotherapy. That is for curative purpose. But as I said, just that is, you have to wait more than a year. So this patient, rather than waiting more than a year, we just send them to Black Lion Hospital for booking. So they will wait for the radical treatment, and at the same time for the palliation, they will get the chemotherapy treatment here. So that's how we are doing so far.
Yeah.
Good afternoon.
Yeah. Okay.
I'm Francine from Bingo.
Okay.
Yeah. So thank you for your presentation. My first question is that you were talking about the palliative chemotherapy. I didn't see, I don't know whether when you have those patients, you agree a dose reduction, because we know that most of the patients that are really wasted, especially those patients with dysphagia, they come with maybe they have lost maybe more than 10% of their body weight. They are really wasted, poor performance status, and especially in low middle income countries where it is very challenging to send to do other modalities. So you want to give systemic chemotherapy, and we know that the side effects are higher with those patients. Do you do a dose reduction, or you give a full dose chemotherapy? That is my first question. And my second question is that when you give palliation chemotherapy, do you do it until unacceptable toxicity, or you stop at a certain level?
Okay, so thank you very much for your question. So you are right. One of the problems with esophageal cancer is adult malnutrition. Because of the dysphagia and the disease itself, most of the patients, if you evaluate them, they present, in addition to the main disease, they will have adult onset malnutrition. So we'll take also BMI, the body mass index, and in those patients who has a body mass index within the normal range, we are providing, we are providing a full dose of chemotherapy. And most of the patients in our experience, they are tolerating the chemotherapy in full doses. But for those patients who are underweight based on the BMI, you know, it's not a good practice to administer a full dose of chemotherapy, and we had experience of doing that. In patients, the toxicity profile, you know, it is exacerbated in such kind of patients. So I think what we can do is you have to take both height and weight, and you have to calculate the body mass index. And for those patients within the normal height and weight, I mean, the body mass index is within the normal range, you can administer the full dose of chemotherapy, because we want a good effect of chemotherapy. The moment that you decrease the dose of the chemotherapy, the effect is also decreasing. But if the patient is having a poor, I mean, malnourished, or the nutritional status of the patient is good, the chance of chemotherapy to work on that patient is also decreased. So you have to also adjust